Yeah, mine is live
Got
as
it.
well.
All right.
All right, I think we are live. Good evening. It's March 10th, Wednesday, 7 p.m. It's not, it's 7:08. This is United Medical ACO Diabetes Program, and I'm here with Dr. Handal, Amy Wilcoxon, and Donna Dunkel. We are going to discuss the diabetes once again. So I'm going to pay attention and then make sure I learn a lot, Dr. Handal. Every time I'm doing this, I learn more stuff. So Dr. Handal is our program director. We have our presentations, and Amy is also running the program with Dr. Handal. So I'm going to ask them to introduce themselves, and then I'll start the PowerPoint from there.
Right, Dr. Handal, do you want to go first?
All right. Yes, I'm Ripu Handal. I'm one of the endocrinologists in local area in Delaware, practicing for last almost 20 years. So I've been part of the United Medical ACO, director of the first state endocrinology. We have 2 offices, one in Newark and the second office is in Middletown.
And I'm Amy Wilcoxon. I'm a registered dietitian and diabetes educator. And I work in the United Medical ACO and seeing a lot of Dr. Handal's patients. Keeps us busy.
It's a teamwork.
Yes. And so our Wednesday webinars, we hold twice a month and talking about all the different facets and aspects of diabetes. All right.
Yeah, once we'll be done with all these series, I'm pretty sure Kamal will put a MD at the end of his name and start practicing.
I'm learning slowly.
Yeah.
So I'm just sharing the PowerPoint right now. So Donna, if you would like to please introduce yourself as well.
Sure. Hi, good evening, everyone. I'm Donna Gunkel. I am a nurse here at United Medical ACO and the director of clinical integration. So I oversee the diabetes program as well as our nurse team and our care coordination team.
And our behavioral health.
Behavioral health too. Yes, sorry. Have many teams now.
All right. So with these sessions, our goal is to be more available for our patients, especially those who are dealing with diabetes. This is a challenge, and from the personal standpoint, we all deal with different types of issues with our diet and eating habits. And I believe making these available for our patients, we are able to cover so many different parts of the diabetes management. Today, Dr. Handal and Amy will be presenting for us. So Dr. Handal, I'll start with you, and then we can try, if you would like me to give you access to remote control, and then we can try that, so then you will be in charge. Otherwise, I can.
Yeah, you can keep
Okay.
changing. I mean, I don't think so. It's straightforward.
All right. Now, Dr. Handal, with your practice with first aid endo, right now we have about 5 providers there, right?
Yes, right. We have 5 providers. Hopefully, down the line, trying to get another one. So
Yeah.
since it's a busy practice and there are so many people, it's not just the diabetes endocrinology. It's a very, very wide field. So we need more endocrinologists all over Delaware.
Absolutely. All right. So, okay, Dr. Handal, you're on.
All right. So today I just decided, while we're talking about diabetes, just to give some basic understanding of the concept of what diabetes is, how it's diagnosed. So we'll slowly then go up the ladder. Then we'll talk about down the line lectures about individual drugs, complications. So let's just, today I want to spend some time on the basics of diabetes. So this is the slides from the CDC. Over time, as you know, with our lifestyle changes, eating habits, more and more people are gaining weight, and diabetes and obesity goes hand in hand. So this is the one showing in 2004, the prevalence of percentage of patients with diabetes and obesity. So if we go with the next slide, this is 2010. You see how they are more darkened colors. So the incidence of both diabetes and obesity, again, going higher and higher. And then in 2016, next slide, you see now it's much all over the place. So with the years, people are leading more sedentary lifestyle, eating wrong type of food, gaining more weight, which worsens the insulin resistance and makes people more prone to develop type 2 diabetes. Next slide. So it's not just a US problem, it's a global problem. So in this slide, if you see, this is the number of people with diabetes. In the United States, it's now actually close to 34 million. So the top countries, mostly India, China, and the US, these are the three top countries which have more than 20 million adults with diabetes. And then the other countries also following suit. Slowly, the prevalence is going higher and higher. So this is a sort of a, you can say nowadays, a pandemic type of chronic disease that where we need to get more involved and try to take care of it earlier on and prevent all the complications and the healthcare cost associated with its treatment. Next slide. So currently in US, there are 34.2 million US adults have diabetes. And 1 in 5 of them don't even know that they have it. They haven't been to a physician. They do not have the typical symptoms. But when you do the blood test, you find out that, oh, yeah, yes, you have diabetes. And we find it quite often. Patients come to us for a different reason. And then slowly with their blood test, other symptoms, we tell them, oh, yeah, by the way, you have underlying diabetes, which he or she wasn't even aware of. Diabetes is a 7th leading cause of death in the United States. It is the #1 cause of kidney failure, lower limb amputations, and adult blindness. And with it's, as I explained in the previous slides, that the obesity incidence is going higher and higher. That's why the number of adults diagnosed with diabetes has really doubled over the last 20 years. Then on top of that, there is pre-diabetes, which in the next few slides I will explain to you, but pre-diabetes is a precursor to diabetes. There are 88 million adults who have pre-diabetes. So 1 in 3 adults, they have this type of problem. And still a lot of people, 84%, don't even know they have it because they are totally asymptomatic. This is mostly diagnosed by blood test. So at that time, if you haven't been to a doctor, haven't followed through your labs, it can be quite often missed. And in the down in the bottom, it's shown that it's on a global picture. So they're saying is number of people with diabetes worldwide, it's 1 in 12 have diabetes. Then in 1 in 2 people with diabetes don't even know they have it. So at least in the US, we are doing better as compared to the global diabetes prevalence. And then it's a lot of people die from diabetes. The #1 cause of death is cardiovascular disease. So there is almost like 1 every 7 seconds, 1 person dies from having diabetes. There are, and this is mostly the 77% of the people with diabetes are in countries where there is low or middle income class people. Next slide. So we talked about pre-diabetes, diabetes. So how do you define them? So normal fasting blood sugar should be below 100. If somebody is given a glucose, like a standard glucose load, then these are standard criteria. We check their blood sugars 2 hours later. Ideally, it should be less than 140. And A1C, that is a test which tells us average blood sugars over the last 3 months period, that should be below 5.6. So that is by criteria for a normal subject with no history of diabetes. Then in the middle is the pre-diabetes. So now if the fasting blood sugar is above 100, but less than 125, if we do a glucose tolerance test and the 2-hour glucose tolerance test, the blood sugar is between 140 to 199. Or if we do the A1C, then it's 5.7 to 6.4. So these individuals are classified as pre-diabetic. And then the diabetes classification is when we do blood test and the fasting blood sugar is 126 or higher. If we do a 2-hour test after glucose load, if it's above 200, or just random blood sugar. Person is sent to the lab and random blood sugars, no relation with what was the last time you ate, or if random blood sugar is above 200, that is by definition is diabetes. Or they have symptoms where they are peeing a lot, having extreme hunger, frequent urination, blurred vision, unexplained weight loss. These are also symptoms of diabetes. And then if the A1C is above 6.5%, that's by definition is diabetes. So this is how we define normal subject, pre-diabetes, and then diabetes. Next slide. So once you have made a diagnosis, what type of diabetes can it be? There are different types of diabetes. So type 1 diabetes is considered autoimmune disease. In our body, pancreas, that is the organ which makes insulin. There are islet cells which make insulin. So they can be gradual destruction of these beta cells, which can lead to deficiency of insulin, and that person will develop type 1 diabetes. This accounts for 10% of the cases. The majority, 90% of the cases, are type 2 diabetes, where there is insulin there, but it's more, the body is more resistant to the action of insulin. So later on, there is gradual decline in insulin secretion. So it's a combination defect of decreased insulin supply, and then the insulin is not working on the target organs to do what it's supposed to do. And then these are other types of diabetes, rare types. There can be genetic defects in the beta cells to make insulin, or there are problems with the receptors where the insulin attaches and does act on the cells to move the glucose inside the cell, that if the receptors are defective, then it won't work. Then there can be diseases of the pancreas, that if there's a pancreatitis, people who drink a lot, alcoholic, they can develop pancreatitis. So it's not working, they won't be able to make insulin. Then some drugs like steroids, or these are new type of immunotherapy drugs used for cancer treatment, they sometimes can induce diabetes. And then the last one is called the gestational diabetes. That is when someone develops diabetes when they are pregnant. So before pregnancy, there was no diagnosis, but anyone, if they develop diabetes during pregnancy, it is called gestational diabetes. So these are the main types of diabetes. So we have to, after diagnosis, have to classify to which category they belong to. Next slide. So the type 1 diabetes, it's an autoimmune disease. So the antibodies results in slow destruction of the islet cells, the beta cells. So this is usually, they typically have family history, parent, brother, sister, somebody in the family have type 1 diabetes. They can develop diabetes any time in their life. Previously, it used to be thought that, oh, it can develop only in kids. But now, I mean, it can develop any age, adults, even elderly. I have patients who developed type 1 diabetes when they were in 60s, 80s. So this is also called latent onset autoimmune disease of adults, or LADA, L-A-D-A. So it can develop anytime. So don't think that, oh, if you are 60-year-old and if you develop diabetes, it has to be only type 2. No, it can be type 1. Those individuals are usually on the thin side, and when you check their insulin secretion, they are not making much insulin. So it's important to remember that. The other risk factors shown on this slide, and again, these are with the breastfeeding, with the type of diet you're on. This is, again, all theories, nothing. There's some say there may be some viral inflammation which destroyed the islet cells. It's not clear cut at this time, like exactly how the autoimmune process starts. But again, if most important risk factor is if your family history of type 1 diabetes. Next slide. In type 2, it's a little bit more clear who are at more risk for developing. Next, yeah. Who are at risk for developing type 2 diabetes. So again, if somebody has pre-diabetes, they are at higher risk. If you are overweight, if you are over 45 years of age, you have a parent, brother, sister with type 2 diabetes, there is also a genetic component. If you are less physically active, like less than 3 times a week, if you had previous history of gestational diabetes during pregnancy, or given birth to a baby who weighed more than 9 pounds, And then certain ethnic groups, African Americans, Hispanics, Latinos, American Indians, Alaska Natives, and Asian Indians, they also are at higher risk for developing diabetes because of the genetic defect, because some of them have more visceral, means more fat in their abdominal area as compared to overall in their thighs or in the arms. So they tend to have more fat in the belly, and that makes them more insulin resistant. And that also, the last one, it's called non-alcoholic fatty liver disease. That is also called fatty liver. So if somebody is diagnosed with fatty liver, they tend to be more insulin resistant and more at risk. Next slide.
So I was just going to say that I was, I think, 10 and a half, and my brother was 11 pounds when we were born. Now it makes sense why my mom has diabetes.
Yeah, again, I mean, there are some genetic variation too. Sometimes, again, I don't know about your mom. There's some individuals like both parents, they are tall, they are big. So the baby can be 9 pounds or bigger. But again, yes, in general, if it's 9 pounds or bigger, then there's a risk of developing diabetes. But at least that's why you stay so slim, and so you won't have that problem down the line. So why we keep worrying about diabetes? Why we are so much focused? What's the problem of having diabetes? These are the long-term complications which we have to be concerned about. The acute complications are immediate, like obviously if you have diabetes and on some medication which can cause low blood sugars, patients can pass out, can have seizures or some other problem. So that's more like acute complication. Sometimes there is another condition called diabetic ketoacidosis, which can happen more often in type 1 patient, where because of the lack of insulin, they form a lot of ketones in their body, have a fruity odor, and then they start throwing up, nausea, vomiting, get extremely dehydrated. And then the third one is more seen in, this is called non-ketotic hyperosmolar state, which is seen in more common in type 2 patients, where the blood sugars may go in 1,000, over 1,000. But they do not have diabetic ketoacidosis, but they can get more confused, extremely dehydrated. And the fourth one is called the lactic acidosis, where buildup of lactic acid in patients with diabetes. Sometimes there's a drug called metformin, and that can contribute if somebody develops acute renal failure or congestive heart failure. So these are all acute complications. The chronic complications are classified under two categories. One is the microvascular disease. So these are small vessels are affected. So the nephropathy, that's the kidney damage, retinopathy, that's the eye damage, and then the neuropathy, which is your nervous system, they can be affected. The macrovascular disease, that is, the macrovascular disease, that's my dog, and somebody rang the bell. Sorry about that. The macrovascular disease is the one where people die from. The coronary artery disease, heart attack, stroke, then the peripheral arterial disease. That's the amputation. Suddenly there is a blood clot. I mean, there's a decreased circulation in the lower extremities, and they have poor supply to the lower extremities, develop foot ulcers, and ultimately leads to amputations. And these individuals are at very high risk of early death. So that's where the more focus is, that if we can prevent, because the number one reason of death in a patient with diabetes is macrovascular disease, cardiovascular disease. That's what we have to prevent. Next slide. So, but this is the same things which I explained earlier. This is same depicted over here: eye disease, glaucoma, cataract, renal failure. I showed in the first slide, number one reason for the end-stage kidney disease going on dialysis is diabetic nephropathy. Then in the foot, poor circulation, ulcers, that leads to the diabetic foot problems, stroke, heart attacks. Then the nerve damage, which causes numbness, tingling. People can't feel their feet, develop foot ulcers easily. And the last one, the blockages, cholesterol deposits in the blood vessels, leading to poor circulation and amputations of the lower extremities. Next slide. So this is just slide showing that individuals with diabetes shown in yellow. This is showing the cardiovascular heart disease mortality, cardiovascular disease mortality, and total mortality, the risk for dying. So if you see that the first one is green one, which is none, that's the relative risk of dying from heart disease. Second one is the metabolic syndrome, where they can have more abdominal fat, high blood pressure, low good cholesterol. Those individuals are at higher risk as compared to normal individuals shown in green. Then we move to the next one, the patients with diabetes, they have much higher risk. The next red one is patients who do not have diabetes, but have underlying cardiovascular disease. They have also higher risk of dying from heart disease or overall death rate. And the last one is the blue one, is showing if you have diabetes and cardiovascular disease. So if a patient has diabetes, already had a stroke, heart attack, they are at much, much higher risk of having cardiovascular events, means dying from cardiovascular disease as compared to the other groups. Next slide. So in diabetes, what happens? It's a long course. It's not in type 2 diabetic individuals, that's what I'm talking about. So it doesn't happen overnight. So the pre-diabetic state lasts for 10 years, 15 years. I mean, patients slowly, the patient develops insulin resistance. So shown in the bottom, the blue one is the fasting glucose. So with time, as pre-diabetes progresses further, the fasting blood sugar slowly starts to rise. Then the green one is the postprandial glucose after meals. That starts rising earlier than the fasting blood sugar. So their body is not able to make sufficient insulin, which is shown in the blue color. If you see that insulin secretion on the top. So initially in a pre-diabetic state, patient is more insulin resistant. So what does body does? It makes more insulin to overcome the resistance. So that's why the insulin secretion is so high. It keeps on fighting the insulin resistance. That's why the insulin secretion, the blue graph, if you see, it starts going, it's going higher and higher. But when the time comes that it can no longer keep up with the insulin secretion and it starts falling down, that's the time when somebody will be diagnosed with diabetes, either by different ways. And the insulin resistance shown on the top is the pink graph. You see, that persists throughout the life of an individual. So the body is insulin resistant, it's not working properly, it's not pushing the glucose into the cells, and it stays more in the bloodstream. So with all these different things which happens during the lifetime of the individual, shown in the bottom are the complications. So complication starts very earlier on. Microvascular disease, where kidney damage, eye damage, macrovascular disease, the heart attack, strokes, poor circulation. If you see, actually the macrovascular complications develops even in the pre-diabetic range. And as disease progresses, then it becomes more and more worse. So that's why we always stress upon is to take action very earlier on. If somebody has developed pre-diabetes, look at the risk factors, keep their cholesterol levels in a good range, adopt healthy lifestyle changes, try to make them to lose weight. So these are things which can make a big difference in terms of decreasing the risk of complications and developing diabetes down the line. Next slide. So in diabetes, it's a lot of patients, when they come to the office, they ask us, okay, why not only one drug? Why you are using 2, 3, 4 drugs? Why what is this? So in diabetes, it's not a single organ defect. Multiple organs are defective, which leads to high blood sugars in the blood. So in this slide, on the left-hand side is the liver. That's called the hepatic glucose production. So the liver tends to, it stores glucose during the daytime. When we are eating, the excess glucose is stored by the liver in form of glycogen. So when we are not eating overnight, our brain still needs glucose. So the liver breaks down the stored glucose in form of glycogen back into the glucose so that our brain can keep thriving on the glucose. Now, when we eat during the daytime, the glucose production by the liver shuts down, but that's not the case in patients with diabetes. It keeps on making more glucose. Now, the second in the kidneys, the shown in the bottom. Kidneys is the only way we can get rid of extra glucose. So it spills over and the body tries to dump extra glucose out of the system. But in patients with diabetes, the kidneys tends to reabsorb that glucose back into the bloodstream, and that leads to high blood sugars. Then the fat cells, shown in yellow. Normally when we eat, the fat cells and the muscles, they take up glucose. But when somebody is insulin resistant, that doesn't happen. So the blood glucose stays within the bloodstream, doesn't go up. Then at the level of the brain, shown on the right-hand side, is the brain sends signals to the pancreas to make more insulin. It's thought that there's some defective signals that doesn't happen as it should. Then in the middle top is the pancreas, which is supposed to make more insulin. But on the other hand, there is a defective insulin secretion and the other hormone called glucagon. That is a hormone which maintains the glucose within, also sort of increases the glucose level. So that's why if you remember, some people who have diabetes type 1 or type 2, we use glucagon to quickly reverse the low blood sugar reaction. So that we give glucagon that helps to raise the blood sugar. So in individuals with diabetes, they are defective insulin secretion and they have then increased glucagon secretion. So both of them then leads to high blood sugars. And the last organ, which is again defective, is the gut. Normally when we eat, our gut hormones, there are different hormones which are made by the gut, which helps to increase the insulin secretion. This is called incretin effect. So that the mechanism is defective in people with type 2 diabetes. And the last one is the absorption of the glucose. People with diabetes, they tend to eat more, eat the wrong food. That gets quickly absorbed into the system, which pancreas is not able to cope with sufficient insulin secretion, and that leads to high blood sugars. Next slide. So these are the symptoms of diabetes. Again, it depends upon where the blood sugars are. As I explained earlier, in mild diabetic individual or in pre-diabetes, you may not have any of these symptoms. But typical symptoms are they tend to pee a lot, because when their blood sugars are high, where do you dump the extra glucose? In the urine. That's how people will feel that they have to go to bathroom quite often. When they are dumping more glucose, it pulls out a lot of water with it. They urinate more, they get dehydrated, so they feel more thirsty. Then they're losing a lot of calories in the urine in form of glucose. They start losing weight. They're very hungry, they're eating, but they're losing a lot of calories in the urine. The lens in the eyes, they get swollen, they have blurred vision. Depending upon individuals, some people may have numbness, tingling start very earlier on. They feel exhausted because of the dehydration, they have dry skin. They may have sores which does not heal properly or takes a longer time. They have more risk for infections. So a lot of these things then lead to these type of problems or symptoms. Next slide. So in terms of if somebody develops diabetes, then as I explained earlier, we need to get aggressive, try to bring their blood sugars quickly down. So what are the current recommendations? So as I explained earlier, the A1C gives an idea about the average blood sugars over the last 3 months. So it should be, we should aim to keep A1C below 7%, as this has been shown to decrease the risk of complications, like prevent less damage to the kidneys, to the eyes, to the nerves. And if we try to bring A1C quickly down very earlier in the process, that may go a long way in preventing heart attacks, stroke, or poor circulation in the lower extremities. Again, as lower you go, the better it is. Even A1C maintaining less than 6.5, but we should avoid low blood sugar reactions. So again, every individual, we may have a different target goals. If somebody is older, has the limited life expectancy, or prone to severe low blood sugar reactions, then we can cut back on the A1C, not bring it too low, maybe keep it below 8. So again, everybody, you have to talk to your physician, and your physician can tell you what will be the right target goal for the A1C. Next one. So we want to keep the A1C below 7. If somebody is monitoring their blood sugars by finger sticks, by the glucose meter, then we want to keep the blood sugars, fasting blood sugars or before meals blood sugars between 80 to 130. And if you're checking blood sugars 2 hours after meal, below 180 or below 150 is a better number to deal with, to aim for. And if you keep your target goal like this, your A1C will stay below 7%. That's our goal for a good diabetes control. Next slide. So in this slide, it's just showing in general, as I explained earlier. So what should be the target goal? That has to be individualized. It's not like one A1C goal for everyone. So again, it's showing on the top is risks potentially if somebody has low blood sugars or adverse drug adverse effects, then again, you cannot aim for low A1C. Then just let it run a little high. On the higher side, then the A1C of around 8 will be suitable for that person versus somebody young. He can tell when the blood sugar is lower, he can quickly act and take care of the things. You can then try to aim for a lower A1C. Somebody with diabetes duration for 15, 20, 30 years, just keep it in a reasonable range. We don't need to get too aggressive because the risk of low blood sugar is much more. Patients can certainly fall down, hit their head, can have brain bleed. They are on blood thinners that can cause problems. They can have a hip fracture. So again, don't take low blood sugars too lightly. Then life expectancy, somebody has a shorter life expectancy. You don't want to be aggressive control. Let them enjoy their life. Keep them blood sugars in a reasonable range. Somebody with multiple complications, we don't again have to get too aggressive. There are some patients who are well motivated. They may say, I want to keep my A1C close to 6. And if they can do it, well and good, as long as they are not putting themselves in danger or frequent low blood sugars. And then also support system is important. Some people have a lot of people at home, their families, they can help them versus somebody living alone, older individual, he doesn't have help at home, he or she, in those individuals, we will try to play it safe and not get too aggressive. I think that is the, let's go one more. And I think that, yeah, that was the last slide. So again, that's the just in general basics of what type 1 diabetes is, how we can sort of try to diagnose it. If you have pre-diabetes, try to get aggressive from day 1 and try to keep it under better control, work with your physician. And if you have developed diabetes, then try your best to bring it quickly down, keep it under control, so you don't end up with long-term complications. Thank you.
I have a question, Dr. Handel.
Yes.
So when we talk about the progression of diabetes, and I know when I explain it, I'll often start with what you're like with insulin resistance, and people have that first. So do you see, you're testing people's insulin that you see who don't have diabetes. Do you think that insulin should be more widely tested if someone's coming in who is overweight? I mean, they're always testing their glucose, but no one is testing insulin except for endocrinologists.
Yeah, I mean, again, insulin, I usually tell them, but again, these are some of the assays are not standardized. Then also insulin, some people, their fasting insulin may not be that high, but the postprandial insulin goes much higher. So it's not easy. You have to look at the overall picture, but again, you have to also, the person who is doing it should understand what it means. So if somebody has normal insulin levels at one particular time of the day, and you said, oh, you don't have insulin resistance. So, I mean, that will be wrong thing to say.
Anything, yeah.
So again, yeah, so always again, order a test, which you can interpret and tell the person, okay, this is what it is, and do the test only if it will help you to make a clinical difference in the life of the person. So yes, we check a lot of times insulin levels in people with polycystic ovary syndrome. They are very insulin resistant. Some people I've seen that their fasting insulin levels are very high. Some people, they are not that high, but we know from their other features, their A1C is on the higher side, they have typical features of polycystic ovary syndrome, we know they are insulin resistant. So just based on one number, I'm not going to write them off and say, okay, you are fine. They are insulin resistant. And most of people with who are morbidly obese, they tend to make more insulin. They are, but they may not, some people may not develop diabetes at all. You have seen people with BMI of like 60, and they don't have diabetes at all, because their pancreatic cells are very viable. They keep on churning out more and more insulin. It's widely available, and it keeps the blood sugars tightly controlled.
Good genes.
Actually, in the bariatric program, the Pandal, we see there are different groups of patients, but 55 BMI, and then their A1C is like better than mine.
Yeah, right. Yeah.
But on the other hand, we also see patients who never had their A1C before in that program, especially because we had the daily case conference. So every patient, we have to just go through everything. I see that, let's say, in many cases, primary care never ordered A1C before. And then because of the program, we do it. And then all of a sudden, A1C is like 11, 12. I mean, you see those patients, of course, later on. So I think the treatments, before the treatment, identifying these patients and utilizing the test, and like we had our ACO meeting right before this one, and that's just like the utilization of the orders in a good way. I believe we do a better job than many other groups, but I think it's important for physicians to engage the endocrinologists, nutritionists before it's too late, because I see patients are struggling with, once they're diagnosed, they are struggling with what's happening with their A1C level, and they're then overwhelmed, and then everything else is happening at the same time. So
usually, I mean, it's some wait until the last moment when it's okay. It's keep on trying, and it's not coming down, then send to a specialist. But again, I think it's just a team approach, as you mentioned earlier. Just ultimately, we are working together to make life better for that individual.
All right, so Amy, I'll go back to the PowerPoint. I think we are starting with your slide.
Okay. Okay, so I've talked a lot in this series about nutrition with diabetes. And so we've talked a lot about if you eat too much starch, you eat too much sugar, it's going to make your blood sugar go up. And I think a lot of people know that carbohydrates are sort of the enemy for a lot of people, which they're really not. So we're going to talk about that too. But what about fat? What about protein? A lot of people don't talk about food as food. They talk about food as carbohydrate, fat, and protein. So we're going to talk about what those do. What types of meals give you a slow rise and fall of blood sugar? Because that's what you want. You don't want that quick spike of blood sugar after a meal. You want it to go up slowly to more match. Well, if you're taking insulin, to more match it, but you also don't want to have a lot of insulin going to work with that food. And then what about net carbs? That's something else that people talk a lot about. Well, it's no net carbs, and that doesn't really mean anything, as we're going to see. So we'll talk about that, and fiber and sugar alcohol. So if you could go to the next slide, please. Thanks. So what elevates blood sugar in general? If you eat too many carbs in one sitting, so this is something a lot of people know, particularly refined carbohydrates. So as a reminder, refined carbohydrates are carbohydrates that are stripped of their vitamins, minerals, fiber. So if we take something like wheat, which has the outer kernel where the bran is, which has protein and fiber, which slows down the absorption of the food. If you take all that away, it becomes a refined, like white flour, crackers, bread, pasta, Pop-Tarts, donuts, cookies. Too much of that is going to raise your blood sugar. If you eat too much food at one time, so Chinese food is an example, people will think, well, it's not a lot of carbs, they didn't eat a lot of rice, but it's often a lot of food, and that will raise blood sugar. If you eat refined carbohydrates by themselves, so if I sit down and I eat a bowl of pretzels, white pretzels, that's white flour. So there's no protein, there's no fat, no fiber. It's quicker digested. If I'm going to go for a long run or hike, my muscles use that energy. But if I'm sitting down to work, I don't need that quick energy. I'm going to have that quick spike, and then my blood sugar is going to come down. Carbs are digested the quickest. So that's what happens with those pretzels, 15 minutes to 2 hours. If there's more fiber you're more on the 2 hours. If it's juice, it's 15 minutes. Protein takes longer. It's a 4 to 6 hour period, and fat can take 6 to 9 hours. So 9 hours is more on the end of people who have difficulty digesting fat, but it definitely is the slowest. So you want a balanced meal. So the question on the first slide was, what gives you the slowest, the nice rise and fall of your blood sugar? And that's a balanced meal. So you have some protein, not too much, carb, and not too much, and some fat. Okay, next slide, please. Thank you. So does protein raise blood sugar? High protein diets are really big. So the results are actually mixed. Protein does not usually cause an insulin response. But if you eat excess protein, what is it doing? Some of it is going to convert into glucose because your brain can only use glucose. Your nervous system can only use glucose. If I'm only eating carbohydrate, if I'm only eating protein all the time, some of that's going to convert into glucose. Some of it's going to be stored as fat because I can only use so much protein in one sitting. So, and excess protein is generally not good for a lot of other organs. If it's animal protein, you might have saturated fat. Dr. Hundle just spoke about heart disease with diabetes. So if I'm eating excessive saturated fat, that's another risk factor for heart disease. So, and then also if you're on insulin therapy, there's timing with rapid acting insulin. So it hits its peak in 2 hours. But if you're eating a giant steak, which is going to slow down the digestion of maybe that baked potato with it, your insulin's hitting its peak, but your food isn't going to be fully digested later. So you may have a delayed high blood sugar because of that. So these are all things we have to pay attention to besides just the carbohydrate. Can I have the next slide, please? Thank you. So what does fat do to blood sugar? Fat by itself, so if you were to eat a stick of butter, which I wouldn't recommend, will not raise your blood sugar. Again, not good for your heart though. So like protein, fat does delay digestion. So again, on insulin therapy, that can cause a problem. A diet high in saturated fat is linked to insulin resistance. So Dr. Hundle just spoke about the first stages of diabetes, insulin resistance, and with pre-diabetes and type 2 diabetes. So if you have been diagnosed with diabetes and you have worsening insulin resistance, your diabetic control is getting worse and worse. And if you're eating a lot of saturated fat, that is going to make it worse. Decreasing the amount of animal fat. So we're talking about pork, bacon, sausage, beef, the skin on chicken, and tropical fats, which are also saturated fat. So coconut, palm kernel oil, cocoa butter. So if you decrease the amount of that, you might have an improvement in insulin sensitivity. It might, depends on how far along you are. But if you improve your insulin sensitivity, it will lower your blood sugar. So the research does not show that unsaturated fat causes worsening insulin resistance. So that would be unsaturated fat would be the healthier fat. So that would be things like nuts and seeds and fish and avocado, olive oil, olives. So healthier choices. It's really the animal fat besides the fish that will cause.
Can I say something
please.
for a second? Yeah. So in relation to what you just said, this was when I was at Yale. We did this study where we brought these college from the Yale. I mean, those are the best candidates. I mean, they come for money. They will do all type of research. So we got them and made them eat like initially they ate high fat diet, and then we infused them with fat type of cells to raise their amount of triglycerides and fat in their blood to a similar level what a person with diabetes will have. And these are athletes. They are runners all the time. When we studied them before and after the intervention, all of them developed insulin resistance. So this was only after 3 days of high fat diet. So you can imagine what people we do every day to day, we eat that type of diet and what happens to our body. So it's a inducible state. That's why when people lose weight, the bariatric surgery, they lose all that excessive fat, and the fat cells, I mean, the amount of triglycerides, fatty acids go down, suddenly their diabetes is gone. So it's a reversible state. Earlier we used to think diabetes is irreversible. No, it can be reversed by changing the eating habits and by losing fat through the bariatric surgery when they lose like 50, 100 pounds.
It's a good point, and it's a good point against the keto diet being so high fat that it's not good for your insulin resistance, feeding fat all day. Thank you. So fiber, carbs are not the enemy because fiber is a carbohydrate. So there's been consistent studies that show that people with diabetes who have more fiber have an improved hemoglobin A1C. So the question though is what kinds of fiber that you're eating. When they look at those studies, they're often taken with foods that naturally contain fiber, fruits, vegetables, oatmeal, bulgur, quinoa, grains in their natural state. Unfortunately, a lot of people are eating fiber that's been added to food. So a high fiber tortilla, there's a brand of bread called 647. It's low in sugar, high in fiber. These are added manufactured fibers. They're broken down and they will not necessarily have the same effect on blood sugar as a naturally occurring fiber do. So you do want to choose a real high fiber food. If I could have the next slide, please. So net carbs. This is something that a lot of people will come in and they will talk to me about, that they're counting carbs, but they're only counting net carbs. Net carbs have no legal definition. So you're counting whatever the label says. So it's net, so something is generally subtracted. It's usually fiber and sugar alcohols. So a wheat product naturally could have maybe 5 grams of fiber in it because it's milled. It's not going to be as high as something like a bran, an intact bran that's higher. But when we're looking at something like this, these low carb tortillas, we will see maybe sometimes 9, 10, even 12 grams of fiber. And so that's added fiber that's in. It is good for weight management. It's very filling, but it's not necessarily going to help with blood sugar. Now, if it helps you from overeating, that might in turn help with blood sugar. But if you're counting carbs, you need to count all the carbs, not just the net carbs. And if I could have the next slide, please. So can I subtract the fiber? There is a rule, and I hear a lot of variations of the rule. So in the next couple of slides, we'll talk about exactly what it is. But there is a rule with subtracting fiber. Fiber and sugar alcohols have some carbohydrate. So in sugar alcohols are used as a replacement for sugar in products. They have less carbohydrate than sucrose and sugar does. So they're used in ice cream and cake and candy, things, diabetic cookies, things like that, erythritol, sorbitol, mannitol. So the rules are, if you have type 1 diabetes and if you have a set dose of insulin, so if you're always taking 4 units with a meal or 6 units with a meal and you're not using a ratio, or if you have type 2, use the total carbs on the label and do not subtract the fiber. If you have type 1 and use an insulin to carb ratio, and if the fiber is more than 5 grams, you can subtract half the fiber from the total carbohydrate. If the sugar alcohol is more than 10 grams, you can subtract half the sugar alcohol. So we still don't subtract all of them. And that's generally because if you have more than 5, it may not always be naturally occurring fiber that's in there. You may have an added product, and some of that fiber may have an effect. So it is important to pay attention to the actual label. So let's look at a label here and take a test. So, and we'll show you in the next slide what this actually is. So the serving size is 2 cups, might give you a hint. And you can look to see the total carbs are 13. The total fiber is 4, and the sugar alcohol, this is a tricky one, it doesn't say sugar alcohol, it says erythritol, but I told you that's a sugar alcohol, and that is 8. So would you subtract your fiber or your sugar alcohol? And the answer would be no, you would not, because it's not more than 5 and it's not more than 10. So the net carbs, there really is no net carb. Now, if you go to the next slide, you'll see what this is. It's Quest, which is a high protein product, peanut butter cups. And look at the front of the package, it says 1 gram net carb. So that is really a big lie because we saw it had a lot more carbs in it, but they can subtract whatever they want. There's no legal definition. You can't sue them for this. So you absolutely have to read the label. It's really important to know that the only thing on a package that's government protected is the label. They can say whatever they want on the front. It's marketing. And I appreciate this. Not true. Absolutely not true. Thank you. And the next slide, please. Oh, I lost my not true. Huh? So the bottom line, protein, heart healthy fats in the diet in reasonable quantities. So you don't want to eat a giant steak just because it doesn't have carbs in it. It's still a giant steak and that is good for you. You want to have a heart healthy fat in reasonable quantity. If you don't know what a reasonable quantity is for you, that's our job as dietitians to help you figure out, because everybody's needs are different. I might only need a half of a potato with my meal. Somebody else who's more active, who's bigger, might need a whole potato. So that's our job to help you with that. Remember that carbs are your main source of energy. But instead of looking for low net carbs, so going through the store, oh, this bread only has 5 grams of carb, you want to look for what doesn't have a lot of sugar, what has a lot of fiber, what has less extra stuff in it. And these are some examples. In intact grains, so something that's not milled into a flour, like bran, oats, farro, wheat berries, and quinoa. Those are intact grains. Berries, pears, and apples are all nice high fiber fruits. And then really the key is the last one, watch your portion size, because you could eat something like a nice bowl of oats, but if you eat too big of a bowl of oats, it's still a problem. All right, and that was it for me. Thank you.
All right, so I think Dr. Handal is closing the office. Dr. Handal, are you
Still here? Not.
I know you're in the office still, right?
No. I'm home.
Oh, you're home? Okay.
Right.
Now I feel a little bit better.
Yeah. No. I won't stay there so late. So I just came early because you had that 1 hour meeting, the other one too.
I did pretty quick though, right? Like that.
Yeah. No, that was quick. Yeah, that's good. Up to point and quick.
Yeah. So one of the questions that I have, I did discuss this earlier with like in the other session with other specialties. What's your position on the intermittent diet, and then how that can be, or can it be utilized for the patient with diabetes?
Are you asking me, Dr.
intermittent?
No, you and I, we talk about it.
Yeah, you already know my opinion.
You're talking about intermittent fasting? What was your question?
Yeah, like what's your opinion on the intermittent diet, the fasting?
Fasting, okay, yeah. Again, you have to do it cautiously. I mean, all these types of diets, they work. They have done studies in the past. You eat less, you lose weight. There's no magic about it. They've done studies with, I think there was a study maybe 10, 15 years ago, where at that time, all these Nutrisystem, different type of diets, they did study. After 1 year, they lost all of them the same amount of weight. And after end of observation period, all of them gained back. They were same as before. So usually I tell people stick with the diet which you can sustain on. Short-term courses, intermittent fasting, that's a good thing. You eat less, it gives you a jump start. But if you can maintain that weight loss with activity and eating less, then it makes sense. Most of the people, what they do is they go for it, lose weight, then afterwards slowly go back to the usual. That's a typical course I see all the time. From diabetes point of view, you have to be careful because some of these medications are long-acting medication. When they are on insulin, when they are on other drugs like these are called sulfonylureas, that can lead to severe low blood sugars. These new class of medication, which we will discuss maybe in the future lecture, I mean, it's very important to keep yourself well hydrated. So if you are intermittently fasting, not keeping sufficiently hydrated, these medications may cause more harm. So just have to be careful. But if you want to do for short term, lose weight, I usually tell patients, they tell me, I said, yeah, stick with whatever diet is good for you and you can sustain for a longer period of time. But sooner or later, you have to go to your usual meals. Main thing, if you can cut back on the portion size and eat a balanced meal, nothing beats that. And exercise.
Mhm. And I've seen some of your patients, Dr. Hundle, who seem to have worse blood, with they very long fasting periods, they seem to have worse blood sugars. So they'll tell me I started intermittent fasting, I lost weight, but now my blood sugar is going up. And I say, well, stop. Let's, eat, watch your portion sizes and eat more often, because it's clearly not working for you.
Yeah, I mean, they are insulin deficient too, and then they stop their medication. They said, oh, I'm not eating, maybe I should stop everything. Like somebody on insulin, instead of cutting back on the insulin, they will just stop altogether, and then that defeats the purpose. They may be losing weight because of now they are hyperglycemic.
Mm-hmm. That's true.
Well, this was very useful. I mean, I'm not really kidding when I say I learn more every time. Even if it's sometimes same session, we pick up different things. I don't know, Dr. Handal, if I mentioned this to you, but maybe I talked to Dr. Irgao the other day. There are some medical students that are messaging me. They find these videos helpful other than our patients. So we are giving so much information, and I do appreciate that for you guys taking time, being available for us late at night. So our next session is going to be the fourth Wednesday. Do we have a date for that fourth Wednesday of March?
So it's March 24th. It's Dr. Barnett Smith and me again. We'll be talking about, Dr. Barnett Smith is going to talk about weight maintenance. So we know all these, as Dr. Hundle said, all these diets work. So keeping it off. And I'm going to be talking about some case studies about people who've kept weight off for a long time, as well as the weight control registry, which studies weight maintenance.
We'll see everyone in 2 weeks. And thank you so much again. And thank you for joining us. Bye-bye.
All right.
All right. Thank you.
Bye.
Bye-bye.